I'm one of the co-organisers for this meeting, and it is my very great pleasure to introduce our next speaker from Queen's University, Northern Ireland, Adele Marshall, who's going to give us a perspective of modelling COVID and the effectiveness of NPIs in Northern Ireland. So over to you, Adele.
Thank you. I'm just going to share a screen.
Oh, I can only see your Zoom at the moment.
Okay, let's try that again.
Still only can see, I think I can see your talk in the background behind the Zoom. You may just need to close that window.
Okay. Another try.
Okay. It's certainly, oh, there we go. Wonderful, wonderful. Right, off, over you go.
Okay, can you see the presentation? Yes. Okay, thanks very much.
It's full screen. It's not full screen at the moment.
Oh, it's not. Let me try that again.
No, just, oh. No, click on the little right down arrow at the right. That's it.
It's not very responsive. It eventually works.
There you go. Now your business. Go for it. I'll shut up now.
Thank you. So thank you very much, everyone, for the invitation to present this afternoon. The piece of work I'm going to talk about today is motivated by my role on sitting on the COVID-19 modelling group for Northern Ireland and the challenges we faced right back when this all started back in March. So it's hard to believe the group's been going well over a year now. One of the things that was of particular interest was the impact that the various different non-pharmaceutical interventions were having on the pandemic in Northern Ireland. And this is partly because there were so many different measures being introduced all at once and variations of them happening across Northern Ireland compared to England, Scotland and Wales and across other countries as well. It was very hard to actually capture what was the true effect and which were the ones that we could be advising our Northern Ireland executive as the ones to continue with, and you know, where we could, I suppose, have most impact with the NPIs. So that's got us looking at the data, and at the beginning data was, it was challenging in terms of obtaining reliable, robust data. It was certainly modelling with uncertainty and having to put together the various different parts of data that we could achieve at that early stage. And of course, this model has developed as time has went on. A lot of the models used initially were more compartmental models that were very focused on using SEER models, where you have the transition represented as mathematical equations, and they were very useful. It meant you got a high level view and you could see and model the perspective from a high level view. The challenge, I guess, for us was sometimes it was difficult. There was a lot of assumptions we were making, and a lot of uncertainty about the assumptions we were making. And as well as that, there was a lot of more detailed information that we weren't capturing by the compartmental model, which is why it drove us to look at agent-based models. So the approach that I'm talking about today is one we've called the change point detection agent-based modeling technique. It uses agents instead. So rather than top down and have like a macro level, we're looking at the micro level where we're looking at each individual as an agent roaming around with various different probability distributions of them being infected and infecting others. One of the challenges with the model was actually being able to direct the agents to behave as we would, as they mimic the population behaviours. And we could see from the data that we had, which was the new COVID confirmed cases per day, that there seemed to be various different changes happening in the dynamics as time progressed. And it was very hard to pinpoint what actually those changes were. There was lots of little fluctuations, as we all know from the graphs we've seen. So we applied a special change point detection technique, which identifies where the most significant changes that were happening and related those back to the key non-pharmaceutical interventions at that time. So identified which ones were the key that caused that change in contact behaviour of the population. And then we fed that information into our agent-based model, which relies on the output from that change point component to adapt the behaviour of the agents according to the NPIs, so that we could realistically simulate the infection spread in the population and quantify the effectiveness of the introduced NPIs. So this is just a diagram of the methodology that we used. We put time series data, so we had the new confirmed COVID cases per day, and we had that. We actually did this over the model I'm presenting today is for the 2 waves. So it's starting back in March, going right through to November in this case. And we're actually able to capture both waves. A lot of the previous work has looked at just 1 wave alone. And so the time series went into change point component, identified the key changes in direction of behavior of the population, and then related that to the key NPIs that were happening, and then simulated that into our agents' behavior. The results of this you can see in the graph. They're very pale probably for you to see, but there's a shaded graph with the different dashed green vertical lines representing a change that the change point detection had identified. And then in shaded colors behind that, we're looking at various key events that happened over the time period that we're modelling for Northern Ireland. So the first graded region there had nothing, no NPIs, no lockdown. The peachy colour, which is next to the right, had our first national lockdown for all of UK. Then we see an area of blue, which saw the introduction of masks. And that was masks on their own for Northern Ireland. There was other public health messaging and other related interventions, but nothing as significant as the complete change in people's social distancing and so on. And then there was a yellow shaded area, which was whenever there was a regional lockdown in Northern Ireland and masks were still introduced. Obviously masks are still, they're part of everyday life now. And then for the pink end region, we had the second lockdown with masks. And you can see there's some aspects of that. You can see where there was just masks, there's other aspects where there was masks plus lockdown, and lots of other measures happening all at the same time. So for the agent-based component, we took those results. The agents represented the individuals in the population. We assume that the susceptibility to infection of the agent depends on their, just move this actually because you can't see my screen, on their age, and we did have different age bands for that. And we modeled this for every single member of the population in Northern Ireland, which is close to 1.9 million agents, matching the age characteristics exactly from the Northern Ireland population, which would have been provided by the Northern Ireland Statistics Research Agency in NISRA. The cells in the model represent infection status, and you can see there the susceptible, there's exposed, you can see the list there, I'm not going to them on this slide. And then one cell is can contain multiple agents, and one agent can be located only at one cell at a time and inherits its infection status of that cell that it is located at. So the agents can move about from one cell to the next. And basically we simulate this, so we have all the population as agents. We set it up to the number that we knew at the time that were infected, and then we let the model fit according to the cases of COVID confirmed cases per day. We let the model fit and estimate all the other parameters. And I'll show you a demo at the time at the end. So if we think of this model, it's an infection-centric agent. So that's where we're focusing on. We're looking at those that are infected and modeling them rather than the entire population. And by doing that, we've managed to really improve the efficiency at running a model for an entire population, which has been a challenge for others. And you can see the various different states there that you can see the infection can move between states from susceptible, shielded to susceptible to exposed, and then from exposed it can be preclinical or subclinical, and then from preclinical they can go on to be clinical, and all of the both subclinical and clinical then can recover. So that's kind of standard from what you've probably seen before. Have we time for a demo?
Yeah, just do it.
Okay. I'll just check to see if you can see this. Okay. Can you see my screen?
I can see your screen with
lots of boxes.
no
masks.
No.
It's I forget what these are called. Yellow
okay,
people.
they're minions maybe.
Minions, that's the word.
I'll stop sharing and resharing just to get the right screen. I think there's a problem with the screen share. Okay, can you see it now?
I can see preclinical and stuff like that, yeah.
Okay, so this is the model that we're just going to show you a live simulation. So we have a colored chart along here. The white are the susceptible, if you like. Then we have exposed in yellow. We have preclinical in orange, and we have subclinical in pink, clinical in red. Green is recovered, and blue was when we had some patients shielding, the over 70-year-olds were shielding. At the beginning of the study, the only thing we knew really was the number of clinical. So we weren't aware of who were asymptomatic, anything like that. We also defined along at the bottom here the susceptibility rates for the different age bands of population, which we took from just previous research papers. And then along the side are all the parameters that we had to estimate. So there's quite a lot of them. And these parameters are really looking at the amount of NPI effectiveness at various different time points. And they are derived by us also estimating the amount of mean daily contacts at various different time points. So I'll just simulate what happens. This is over a 250-day period. This is two that we mentioned, 2 lockdowns that we had. And hopefully this will go and you can see it moving. So here we have each day and we have the pattern that's happening at each point. And so I'll just stop for a moment to let you see what's happening. So we have along the right-hand side, we have the report of each day and the number exposed, preclinical, clinical, and so on. We are mapping here the infection, the COVID infection monitor really is just showing the number of exposed, preclinical, clinical, and subclinical. We're also seeing then the cumulative confirmed clinical cases. The red is our estimate. The black is the true actual observed amounts, and then the blue is the actual with a moving average of 7-day moving average. And then we represent that for daily, and we also represent that for the total cumulative. So really what we're wanting to see is that the black and red are similar. So if I just keep running that, you can see that it starts to map out the pandemic as we go through from the various different days. You'll also see along here little buttons that we switch on and off, and there's one which we call Shield Elderly. So it's been just switched on, and that was after day 19 of this run, which is day 19 of our pandemic really in Northern Ireland. we introduced shielding, so that had an impact as well. So that reduced the amount of mean daily contacts that the over 70s have. And for purposes today, I have just set some of these parameters just to give you the illustration. So as time progresses, you see that we're starting here. Daily confirmed cases is the black line. Our red line is what we've been predicting. And remember, we're doing this from bottom up. So we've got all these agents running around in the simulation with their respective probabilities, whether they're going to get infected or not, and so on. And that every day being updated, which is why we're seeing those FE tick in increasing as we go forward. And this will run, as I said, for 250 days. You can see there, that was our first peak. Then it went down in the summertime, and then in October it really kicked off again, and then you can see how it rose again. There's quite a bit of variability here just in the data, so our curve is just a bit smoother at times because of that. And that will give you then just along here is just giving you the distribution by the preclinical for each age groups, by subclinical and clinical and recovered as well. And finally, when it completes, then normally we would have these parameters all estimated, which we had to use some additional genetic algorithms actually to improve and validate and test all the parameter estimates as well. Okay, so that's really just coming to the end, and hopefully you can see how we've been able to mimic the distribution in the confirmed cases. And remember, that's by capturing behavior with these parameters, which we'll just go back to now in a moment. And you can see the R-squared values, if anybody's interested, is sitting at 0.96 in NSE and so on. Okay, I'll just stop sharing and very quickly conclude the presentation. Sorry, it's a slightly different format than my screen share had worked in my trial run of this earlier today. Okay, so that's just an example of the fits that we've got. So the black being the true numbers and the red being the fitted. So we were pleased that it was a good representation, that we were able to capture the COVID-19 infection dynamics for Northern Ireland. We were able to quantify the non-pharmaceutical interventions at the national level. So we looked at 2 national lockdowns, 1 local lockdown, and wearing masks. We're also able to then retrospectively identify the number of asymptomatic patients or subclinical. And by speeding it up, by looking at infection-centric agents only, we've been able to run this without needing, we've used hardware rather than using cloud to run it. So we're able to save on commute time, which was critical for us, and allows us to predict. So for instance, we predicted scenarios such as the return of schools. And this has been used to inform our Northern Ireland government interventions and policy. Just because of the topic, I thought I'd flag up one in particular for this workshop, which was the impact of wearing masks. So we could see between the 10th of August and 1st of October that only the wearing of masks was compulsory in Northern Ireland. So we could quantify the mask effectiveness by looking at simulating what happens when we've captured the parameters for what happened whenever the mask wearing was mandatory on its own. And we've compared that then with what happens if you go forward and project for the future. What would have happened if we hadn't wore masks or it wasn't made mandatory? And there would have been approximately a 96% increase in the number of reported cases on the 19th day after mask wearing became mandatory. And that we validated that it fits with some previous research that had demonstrated in Germany, 46% showed a reduction in new cases on the 20th day. So that matches it. But we were able to extend that for a longer period of time. And that's something I think people sometimes miss, is that it's the continuous wearing of masks. You don't just stop wearing masks that it's a continuous. And if you simulated it further, you could see a double in that percentage and a triple even within 30 days. And that just gives us a list of, there's lots of further work to do, and lots of things still to work on. Getting the various data, getting the scenarios, there's lots of challenges, and looking at this for more closed regions is something we wanted to look at, looking at clusters and how they're dynamically changing over time. We could look at smaller geographical regions or buildings or so on as well with this methodology. And of course, this goes beyond COVID-19, you can apply it for other infectious disease. Okay, thanks, Chris, you've been very patient.
Thank you very much indeed, Adele, and you persevered very well through the IT glitches, so thank you. That's incredibly impressive agreement between prediction and what we actually see. So we do have time for a couple of questions. I don't see any questions at the moment in either the chat or the Q&A, but if you want to bung a question, great, here's the Q&A. So David Sykes says, have you published any data on the mask wearing, especially considering the agreement with MITSA?
We haven't published any data. We are currently awaiting our paper for review, so we're hoping to publish the paper about the mask wearing, but it hasn't been published in terms of data. The data itself, I guess we could extract the simulated data that we had and make that available, and that's something we can maybe do as a follow-up from our publication.
Right. And
just to say, Sumanas has posted a question, but it's in the Q&A. Sorry, it's in the chat.
In the chat. Oh, thank you.
It says, how were the simulations calibrated?
Yes. Yes, as Sumanas said, how are the simulations calibrated? Yes. For some reason, panelists can't post in the Q&A.
Okay. We calibrated it across a number of different metrics. So we calibrated mean daily contacts, for instance, at various time frames from surveys that Northern Ireland Department of Health had conducted. So a sample of the populations were taken on the mean, COVIX or COMIX measures that we had. So they matched. I think they varied maybe by 0.1 on some occasions, but they were very close. So it actually supported those surveys. We also obviously calibrated with our new confirmed cases, but it also matched some of the research literature as well. So every single metric and parameter that we created, we have it calibrated with research literature and other data.
Thank you very much. That's a very impressive work indeed. So we've got no more questions.